There's very few times in your career where your field changes radically and completely. But recently, this has happened in the field of stroke treatment with the publication of several trials of intra-arterial embolectomy for acute stroke therapy. The first one of these, which literally changed the field overnight, was a study called MR Clean or Mr. Clean. And in that study, the primary outcome was a Rankin scale, which is a good, better, best ordinal scale of functional outcome 3 months after the stroke treatment. And the common odds ratio comparing modified Rankin scores in the embolectomy group to the IV-TPA only group was 1.67, which is highly statistically significant and a powerful message that intra-arterial embolectomy significantly and powerfully improves outcome 3 months after stroke. In several of these trials, 7 to be exact, the therapy was overwhelmingly positive. But you want to know if maybe you can target treatment to a particular subgroup, maybe younger, maybe older patients, maybe severe or mild. And in subgroup after subgroup after subgroup analysis across these trials, and first and foremost in the Mr. Clean study, which was done first, both independently of age and independently of stroke severity, the results were positive. Now, the subgroup analysis has been repeated in all subsequent trials after Mr. Clean, and again, no difference among subgroups. All the trials, but especially this one, emphasize speed, and they set very specific parameters for door to groin puncture and door to recanalization. And they adhered to those milestones that they set for themselves and had, again, a very positive study. And this serves to remind us that previous trials have been negative. Intra-arterial embolectomy has been attempted before, but with longer time windows. So the key to success in these trials, the modern trials, is that they got to the patient early, they set for themselves aggressive time frames, got the artery open quickly, and then had a positive result. So the large trial done in North America was SWIFTPRIME, which used the solitaire retriever. And again, looking at the 3-month Rankin scale, there's an across-the-board shift of scores from bad outcomes to good outcomes, and that was the significance of the SWIFTPRIME study. One unique outcome in the SWIFTPRIME study was on the safety score. So you look at, when you treat stroke patients with either IV-TPA or embolectomy or both, the symptomatic intracranial hemorrhage rate or the ICH rate. And for the most part, in most of the studies that we've been discussing, these were the same between the two groups. But in the SWIFTPRIME study, which had a slightly earlier time to treatment than the others, the bleed rate, the symptomatic ICH rate, was actually lower in the embolectomy treatment compared to the IV-TPA treatment. Now, this isn't definitive proof that embolectomy is safer than IV-TPA, but it's very suggestive that if you get that artery opened quicker, you have better restoration of blood flow, better outcomes, and maybe even better safety.